Mrs. Holness, Member Holness. Any other? Any other? Going once, twice? No? All right, thank you very much. My welcoming remarks are very brief. In the interest of time, there is a 12 noon virtual meeting here, so we have to get out of here 10 to 12, which is normally what we would like to do, a 2-hour session. So we're going to go very quickly. And we do have a packed agenda, the update on the status of COVID in the country, vaccination, program update, and I have Mr. Chris Zucker of the private sector COVID vaccine initiative, COVID initiative, private sector COVID initiative, who is going to come in at 11 or thereabouts. He's at a meeting now, as was requested by the committee, and we'll just spend a little time going through that. So I want to welcome you. To my left are members of the Ministry of Health and Wellness. You should know them by now, but nevertheless, we have the Permanent Secretary, the sole male on that side, very fortunate gentleman. And then from him, beside him, we have the Dr. Jacqueline Bisesa McKenzie, our CMO. We have Dr. Webster Carr, our national epidemiologist. We have Dr. Nadine Williams behind her, and Dr. Hamilton. I keep forgetting your substantive post, Dr. Williams. I know you're very good at what you do, but I just don't remember the title. So if you want to remind us, what's your title again, sorry, or remind the committee.
Morning, sir. Morning, everyone. Director, Health Services Planning and Integration, Ministry of Health and Wellness.
No wonder I don't remember. It's very long, right? Planning and integration and many other things. And then we have, of course, Dr. Hamilton, who is in charge of our lab, who primarily concerned with testing. So let me welcome them and welcome members here. All right, so let me just quickly now go through the minutes. Page 1, the minutes are before you. Page 2. Page 3. Four. 5. 6. 7. 8. 9. 10. 11. And 12. Okay. Any corrections? No? All right, so can I ask for a motion or someone to move for the adoption? Moved by Senator Campbell Rodriguez, seconded by Senator Sapphire Longmore. Thank you very much. Second in the minutes. And then we have matters arising. If there's a substantive matter that's going to be linked to any other presentations, it may be wise to hold on, but let me hear member.
You know, it might be best to hold off. Thank you. It's related to the vaccine and the age.
Right. So maybe you should let us do that and then we can take that. All right, Chairman, if there are no matters arising.
Chairman, mine will be covered by the presentation. Just two quick questions. One, we met the last time on the 16th of March. Can the ministry say whether there has been any update as it relates to the use of ivermectin? That's one. Two, CMO indicated that she would check on the tracking of persons by phone arriving at the airport. And we'd like to know what is the position relating to that. And thirdly, as it relates to the test kits coming into Jamaica and utilization, you did indicate, Minister, that you were also it was of concern to you that more was not being approved. And I have a letter here coming from somebody who applied permit under the signature of the Chief Drug Inspector. And dear John Brown, please be informed that the Ministry of Health and Wellness is presently not, and that was bold for emphasis, approving COVID-19 test kits for importation and subsequent distribution and sale on the Jamaican market for importers that have not been so authorized. The Ministry will provide an update on the importation of the above mentioned once the position changes. Has it? And if it has not, why? And if it has there been an indication to those potential importers that it will be imported?
I didn't get the second question you raised. I hear the ivermectin and the test kits, the current status of test kits. What was the second?
The one about the app for persons arriving at the airport, going on the phone. And there was a complaint coming out of the meeting that persons who had been arriving said that the tracking of persons were not being done because some persons did not get the app uploaded to their phone and the tracking. And the CMO said that she would check on it.
Check on that. All right, so I'm going to ask the CMO to address the first two, ivermectin and the current status, the app and the tracking, and then Dr. Hamilton will speak to other test kits. CMO?
Hi, good morning again, everyone. Right, with regards to ivermectin, I think the last time we spoke, we had said that we will register the drug once an application has been made. So far, my checks this morning was that one company has made an application. However, the critical document which is needed for registration, the bioequivalence study, which says that what it is that you are registering actually has the same safety, and it's the same molecule as the one that has been studied that shows the safety and efficacy of the drug, has not been submitted. We have responded to the distributor to say that this information is needed. I also spoke to the director this morning to say just reach out on a personal note to emphasize the importance of this document so that they can understand why we are waiting still and that they can make efforts to bring it in. In terms of the airport, we have checked.
CMO, if you may,
Sure.
in terms of any update on the use of it, it's 2 weeks ago. Has there been any new information which recommends its use in the treatment for and against COVID-19?
Okay. Well, in terms of new information, we know that there have been studies. What the call has been for there to be prospective randomized control studies. And so far, I have seen one report that is not supporting the use, to say that the study has shown that there is no nothing compared to placebo. So that is just one study, however, and I believe it was just about 400 persons that were involved in that study. So we have not, I'm not sure if Dr. Williams would have seen any other new study that has come out since then. But over the last 2 weeks, or 2 to 4 weeks rather, that is what we would have seen. Certainly we know that there has been a lot of circulation of data concerning the data that has been there from before in terms of the small studies that have shown effectiveness. There has been a resurgence of the just putting out on social media, the conspiracy theories, et cetera, a whole avalanche has come recently over the last 2 weeks. But in terms of new data showing that there is safety and efficacy at the dose that is required, we have not seen that. In terms of the airport, we have done our checks. So what happens at the airport, the process is that persons coming in still do apply on the JAM COVID, and they get their approval, and their approval for travel is based on them signing the quarantine order. So that is still in place. When they come in, our public health persons board the plane, and they give a talk to say what is expected, what the requirements in the country in terms of the quarantine order, what the quarantine order means. And then essentially they pass through the system, the process within the airport. So we have actually asked for a more detailed look to see how it is that we can improve on that. And just to make sure that persons get the message, we've also checked to make sure that the information is being on the video monitors and the other audio that they have at the airport, that those are still being played to tell persons, about the precautions and what is required in country. But the team, our international health regulation teams, have actually submitted a more detailed report that I've not had a chance to review as yet to see if there are any new recommendations.
Okay, thank you. Dr. Hamilton, you want to quickly for me?
Yes. With respect to the importation of antigen kits, I have been advised by the head of standards and regulations that they have not been refusing persons who wish to import antigen kits for use in Jamaica. There are two matters that had come up before them. However, one, a company was asking to import kits that were not the approved kits for use, and those then they would not have been able to approve. They are also verifying whether or not the kits that are being imported really only have one authorized distributor, because we were told that there is an authorized distributor in Jamaica for the companies that have the antigen test kits that we are using, and they have asked him to produce the information to say that he is the only person authorized to bring them in. If that information does not support this claim, then other persons would be able to import those kits. But they said they have not denied anyone the right to import kits at this time, save for and except a company that wished to import kits that were not authorized.
No, but the question, Chairman, is in terms of the numbers that have been authorized. We have been told that there are 3 kits that are authorized. I think the gravamen of the situation is whether there is the desire on the part of the ministry to authorize more kits after they have been approved by the authorities that we usually rely on abroad. And that is where my question is coming from. And while you're at it, Dr. Hamilton, can you indicate to us what is the situation with those foreign companies that we see now as reported in newspaper operating testing sites in Montego Bay at the airport in collaboration with other labs? Are they using one of those 3 kits that are approved by the ministry, or are they using other types that are brought out of the states where they originate from?
With respect to kits that have been approved, we previously had 3 kits that were approved. I now have an update from PAHO that this month, March, they have approved a 4th kit, and that information will be circulated for use. With respect to the testing facilities that have been set up at the airport, we are currently investigating what is happening, because those I can't speak specifically to what is happening in Montego Bay and the company that you are referring to. When you said a foreign company has come in and this has set up operations, I do not currently have that information before me, so I will investigate after.
Okay, so we're at matters arising, and the member has stuck in a question there that hasn't arisen out of the minutes. So I'm going to ask us to hold that, and if you want to expand on it, we can do that during the general discussion section. But thank you very much for those responses, and thank you, member, for the questions. Can we then move on to the presentation, starting with the COVID update? And who's doing that? Is it you, Dr. Webster-Carr? All right, so just go right into it, and then we'll go right after with the PS's update on vaccines. And then we have a conversation after until Mr. Zaka arrives. Go ahead.
Thank you. Good morning, Minister. Good morning, everyone. So we're going to give the update on the numbers as of yesterday. Yesterday...
Sorry.
I'm sorry, I was asking for copies available.
Of the presentation here?
Always remember that some of us still can't see some of the stuff.
We don't have, but I think we had committed to emailing it or sending electronic copies, didn't we?
I don't remember seeing it.
Sorry, I'm being told it was sent. Okay, so you got it today. Did you send it to members? Not yet. She got it late, so we'll arrange for you to get it.
Because
Go ahead.
we get the information overnight. So yesterday we had 389 new cases, carrying to the numbers to 39,237, and of that, 787 are imported, with 596 deaths, with a case fatality rate of 1.5%. With respect to age, the younger people, persons 20 to 39, has the highest burden of disease, of confirmed cases. But when we look at the deaths, persons who are older are the persons with increased fatality rates and increased number of deaths. When we look at sex, more females than males have been confirmed, but more males than females have died, with males having a significantly higher case fatality rate than females. When we look at the distribution by parish, and we really focus on the last 2 weeks, that tells us about the transmission and how COVID is transmitting in the country. Now, we see the highest burden being in KSA, St. Catherine, and St. James. When we look at the number of cases in the last 2 weeks at the per population, then Portland, Kingston and St. Andrew, Trelawney, and Hanover have the highest rates by parish. This just to demonstrate that the majority of communities across the island have at least one confirmed case in the last 2 weeks. When we look at the deaths, the highest number of deaths have been in St. Andrew, followed by St. Catherine. But when we look at the death rates, then Trelawney, St. James, St. Elizabeth, and Kingston had the highest death rates by parish. When we look at the epidemiological curve, and we have on the curve also the 7-day and 14-day moving average, it appears that the number of cases have plateaued, because where we've seen a little dip, it may yet fill out, because this represents the date of onset of symptoms. So it may yet fill out. So what we can say, it has plateaued. And we know we have some cases that are, the lab tests are outstanding, especially those at the National Influenza Center that we are to get in, that are a little dated. So we can say that we have plateaued. When we look at the parish distribution and the parish curves, all the parishes show a similar presentation as the national. Some have a little broader peak, than others. When we look at the weekly numbers, so far, week 10 of 2021 has had the highest number of cases, and then week 11, the highest number of deaths. So the deaths tend to lag about a week after the cases. So what we can say, no, the deaths are increasing. We're not sure if they're coming back down because we are just at the beginning of week 13. On this chart as well, we do have the positivity rate, which appears to be coming down, and also have the bed occupancy, which is above 100% at about 119 this week on Sunday. When we look, so what we're going to take the next few slides on looking a little bit closer on the numbers and how they have changed over time. So this first chart looks at how much time, how many days it took to confirm the first 5,000, then second, etc. So 188 days, followed by 61, 67, and then we went down in January to February to 23, then to 14, then 10, then 9. Currently, we are at between 35 and 40,000, and it's estimated at 15 days. So we have completed 13 days of data, and we looking at it 15. So based on this, you can see that we fell to 9 days, a low of 9 days, but now we seem to have this slowed in the number of cases being confirmed. We also look at the cumulative numbers and taking it from the 14th of November when we were just over 10,000 cases, and in January, earlier January, about a 150-day doubling, and then that shortened, and we are currently at about 70-day doubling. It seemed to be, the doubling rate seemed to be decreasing now. If we stayed on the 70-day doubling, by about the 21st of April, we would be at 50,000. But based on where we are now, it does not appear that we will hit 50,000 till much later. When we look at the reproductive rate, in February, we are at 1.3. Now, around March 17, the numbers are showing a reproductive rate of 1. So if we are at a reproductive rate of 1, it means that we are steady at a certain number. So we are plateaued, but the reproductive rate is not yet saying we are decreasing. But you remember, the reproductive rate lags about 2 weeks or up to 2 weeks. So let's look at the admissions compared to the designated bed, so the occupancy. So we are over 110% bed occupancy, and sometimes at 120% in the last few days or weeks. However, there is a silver lining, and it's in yellow, that the number of admissions are decreasing. So what's on the slide is the 7-day moving average. So I didn't just want to see the volatility of 1 day, but to give you a sense of what has happened over the last 7 days. So it seems that this is a good thing. We did a reproductive rate for hospital admission, similar to what we would do for cases. and it is also showing a decrease in admission. Just to say, persons who have died stayed on average 10 days in hospital and with a range of 0 to 85 days. When we look at the weekly positivity rates, the positivity appears to be decreasing. And this week so far is at 29.5%, and prior week was 30.8%, and the week before 32.4%. So there seems to, in general, a decrease in the positivity rate. So the final slide is really our take home, that we are seeing improvement in key indicators, but at levels that are still too high. So the case numbers appear to have plateaued with a reproductive rate of 1. However, when we look at the 7-day moving average, it's around 400, and the 14-day moving average around 500. So to plateau at 400 or 500 is not a good thing, but there it has plateaued. When we look at the hospital admissions to public hospital, there has been a general decrease in hospital admissions. However, where it relates to bed occupancy, we are still high, 121% on the 30th of March. For the positivity, there has been a general decrease in the positivity, but we are over 25% positivity. So that's not a level that we should be comfortable with. But so there has been improvement in the key indicators, and when we look back, the institution of the measures on the 10th and 24th seem to have had effect. With respect to the new measures over the weekend, you would not see the effect of that at this time. Thank you, Minister.
Thank you very much, Dr. Webster-Carr. I'm going to ask you to just make a note of your questions. We will come back to the report after the PS's presentation. I'm assuming they're putting that up on the screen now. I think the takeaway is very instructive, and we should, I think, take the opportunity to commend the team for the efforts that they have made in the field at the level of the overall coordination. And certainly, I would not want to ignore, too, the extent to which our citizens have been complying with the new, with the protocols, including the most recent. What we're seeing, certainly coming from the last meeting we had, is that the rate of increase of hospitalization is going down. It's a decreasing increase, a decreasing rate. The rate of positivity is inching down, and the reproductive rate, which is the critical indicator, which was at 1.3 at one time, then came down to 1.1, is now hovering around 1, and that really means that for every one person who is infected, they will in turn infect one other, as opposed to 1+. And we have to get that down to 0.7 or so to feel relatively comfortable, I'm told, by the planners and the epidemiologists. So we still have some ways to go, but it certainly is suggesting that the policies and programs by the government are working, the interventions, that there is apparently on the face of it some greater levels of compliance. And we certainly would hope that the measures, the more stringent measures that have been introduced over the last weekend, going into this weekend and the next weekend, we will see the lag effect of that in a few weeks, and that will be more significant adjustment in the positive direction. So I think there's some encouragement there, but not to be complacent at all. PS, you want to just go quickly into the vaccination plan and then we can move on from there. Thank you.
Chairman, Dr. Melody Ennis will take us.
Okay, go ahead, Dr. Ennis. Dr. Ennis came in late. She's in charge of the immunization program at the ministry.
Good morning, everyone. We are going to be looking this morning at what we have done over the last 3 weeks. Yesterday ended week 3 of our vaccination program. And just for recap, in week 1, we had a target of 17,050 persons, and we achieved a 94% in that week, vaccinating just over 16,000 persons. For week 2, our target was more modest at 11,430, and we did exceed that target, going up to 116% when we vaccinated 13,244 persons. Week 3, which ended yesterday, we didn't do so well. We're just under 50%, well, just over 40% to be more accurate, at 42%, vaccinating some 8,168 persons. We continue to vaccinate more females than males when you look at the breakdown, and this breakdown is just for the last week. We still were mopping up for our healthcare workers, and therefore we did anticipate that we would be continuing to get more females than males. We had a big thrust last week on our elderly, persons over the age of 75 years, and that is borne out in the breakdown, the age breakdown that's displayed here. Our over the age of 70, which falls into the group 70 to 79, we vaccinated 17% of the total. We had a large number of persons between the ages of 80 and 90 at 11%, and we did have quite a few, over 100, giving us at 2%. The other large percentages, of course, includes persons who belong to the healthcare sector, the Jamaica Defense Force, the Jamaica Constabulary Force, and at the end of each day's session, when we have additional doses in order to prevent wastage, we have a call-out list of persons over the age of 60, as well as persons belonging to the Jamaica Fire Brigade. And therefore, we have those numbers for persons in the lower age ranges. This is our distribution by parish, and the Kingston and St. Andrew parishes, of course, continue to have the lion's share, followed by St. Catherine, St. James, and St. Anne. We continue to monitor the events that are supposedly attributed to vaccination or immunization, and we have collected just about 40 of those. Most of the persons reported having the expected side effects of the vaccine, which includes the flu-like illness, the real feeling of being tired, some amount of headache and dizziness. All of those persons have resolved within the 72-hour time frame that is allotted for that. We had just about 2 persons who we considered serious, who had to be treated at hospital just for allergic reactions, and they too have resolved and certainly gone home. When we look at the percentages, another pictogram of the persons that we have vaccinated. Healthcare workers continue to dominate our pie chart, and the other groupings are following close behind or just about equal. And then, of course, our elderly, which we have been focusing on. I'm going to hand over to Mr. Bryan to speak to our Blitz mobilization implementation plan.
Thank you very much, Chairman, and thank you, Dr. Ennis. So, we want to remind you of the different principles that underline our vaccination program. Human well-being being one of the main principles that we seek to achieve in the operation of the program. Equal respect being another principle relating to non-discriminatory practices in the distribution of vaccination. National equity is a critical part of what we want to accomplish in our vaccination program, and that is one of the pillars on which we are going to talk about our Blitz operation and the mobilization of community-based action for the vaccination of persons. Legitimacy and reciprocity are other aspects of the work that underpin, in terms of principles, that underpin what we want to achieve in our vaccination program. So the objectives of our mobilization strategy must therefore be to reduce the socioeconomic bias in the targeting. So its principle relates to the reduction in targeting error that can result from socioeconomic bias that can creep itself into any program, public health program, or any other social intervention program for the government of Jamaica. We want to also increase the reach and depth of our communication strategy for all socioeconomic groups within the population, reduce the levels of vaccine hesitancy within the population, and promote a whole-of-government approach to vaccination implementation. So the process of mobilization for us rests and must anchor with the most powerful, the most powerful organization in the country, and that is the political organization. The political organization of this country has been shown since adult suffrage to be one of the key mechanisms of mobilization for all socioeconomic groups. And therefore, we must, as part of our strategy to reduce some of the socioeconomic biases that can arise within social intervention, capitalize on the strength of our political infrastructure to mobilize all aspects of the Jamaican society. Now, the key agency of government that structures this at this time is the Ministry of Local Government and Rural Development. And therefore, that agency becomes the cornerstone agency for the implementation of our mobilization strategy. Therefore, members of parliaments, councillors, persons that operate within the political institutions across the country become so important to the mobilization of persons at the grassroots and the community level that enable them to achieve greater levels of participation and reduction in social bias. So, two elements of mobilization: communication and transportation. And so we need to empower or to resource the organization at the community level to assist with the registration of approximately 100 appointments per constituency, per Blitz site. So every time we have a Blitz, we intend to engage with the different members of parliaments and councillors to mobilize persons to first make appointments on the appointment system that has been launched by the Ministry of Health and Wellness, and then to enable them to communicate at the community level to engage persons and to reduce hesitancy and to encourage persons to participate in the vaccination program. And of course, transportation becomes a critical part of the engagement to create access, because the vaccination can't be everywhere. The vaccination program can't be everywhere. So the ability of persons to access is important. And our principles that I outlined before in terms of engaging geographically and to ensure access for all is critical. So, for communication, the Ministry of Health and Wellness, through the Ministry of Local Government and Community Development, will provide resources to members of parliament and councillors to give them the ability to communicate based on materials that we would have, information, education, and communication material that will be provided, and also to create access through transportation. And so each member of parliament, each councillor, will be provided with resources that will allow them to do this. So we will be piloting this exercise on April 3. So we piloted the entire Blitz operation on March 27, and now we will be piloting the community mobilization in 5 constituencies come April 3. West Kingston, Central Kingston, East Kingston and Port Royal, Southwest St. Andrew, and Southeast St. Andrew. So each constituency for this Saturday, will be required to mobilize 100 persons within their constituency to get them to the Blitz site and to have them vaccinated. Therefore, what we are anticipating to have here is a lot of learning, given that's a pilot. So what we have in the conversations that we have had with the members, specific members of parliament, is to ensure that they document what works and what doesn't work. The target is clear in terms of what we want to achieve, 100 persons vaccinated.
Thank you.
So 100 persons, because come the next week, which is April 10, we will be moving into significantly more parishes in terms of Blitz operations, and the proposed Blitz sites are set out there for April 10, Jamaica Conference Center, GC Foster, Gale Civic Center, Montego Bay Convention Center, Bahia Principe Hotel, Trelawney Multipurpose Center, Denby Showground, Ocho Rios High School, the SDC office grounds in St. Thomas, and Anota Bay Sports Complex. Now, these are all proposed Blitz sites, and they will be finalized in the coming days so that we can properly structure and plan the operations at those sites. But for this weekend, we will be piloting the community mobilization strategy to ensure that community-based involvement in the Blitz operation is maximized. Thank you, Chairman.
Let me just add a couple of things to the presentation. Thank you, PS, for that. First of all, the rationale, and PS and I and the team have spent some time before we have made this a public document. And as he said, it is a pilot. It's an addition to what we did last Saturday by adding another layer. Ultimately, there are 2 significant challenges we face with the vaccination program as a COVID response. One, of course, is not fully in our control, which is accessing vaccines. And I don't need to detain us on the challenges there globally. But we're trying, and I think we're making progress. We have, I'm happy to say, 75,000 doses of AstraZeneca that should have taken flight, or hopefully will take flight sometime today or tomorrow, but certainly will get here on the weekend, which is coming from Africa. And that's very positive, because we were worried that we would go into April and have a difficulty based on the vaccine nationalism that's taking place, and understandably so, countries holding on because of the challenges that they have in their country. We also expect another 26,000 or so doses from the COVAX facility, the 75,000 coming from the African platform, which is similar to the African version of the facility that we have here in this hemisphere. If we get those 2 shipments, well, we're sure of the 75, but if we get those 2 shipments, we would have just over 100,000 doses, and we do expect coming to the latter part of April to receive more. So that's a big issue that I think we have had some relief on, thanks to the efforts of Ministry of Foreign Affairs, Ministry of Health, the NHF, led by Mr. Howard Mitchell as chairman. We have to say thanks to him and his team, because with time zone differences, they have to be up all hours of night trying to call and conference and to make arrangements. Having gotten some relief on that, the issue now is how do we distribute it in keeping with the challenges that the PS has outlined, the mission statement of equity and so on. And when you look at the organizations across the country, you have to touch down at key points of reach and impact. Reach in that we reach the targeted groups, but impact meaning that they have influence over those groups, because the next big challenge that we face, having secured some vaccines, is to get people to take the vaccine. Now, I know there has been a lot of energy around taking it now, because we have had a little bit and we just started the program. But the evidence suggests that once you get past a critical number, which is a minority number, you're going to have significant obstacles because of vaccine hesitancy. People are just not convinced. And so we have identified points of influence. The church, for example, is playing a big role in registering their members and encouraging it. And I've met with the church, the various umbrella bodies of the church fraternity. The senior citizens groups, so like Professor Eldemaya Shearer and her outreach. The political directorate in our country, us here who are elected, whether at the local municipal level or at the level of MPs, have an organization, whether we accept it or not, that is possibly second to none at the very localized level. We have our indoor agents, or outdoor agents, or supervisors, or cluster managers, and I could go on. And so our unit of organization, some, okay, some, well, the ones that are in office, that are elected, right, well, clearly have shown some superior organization. Those units of organization has the capacity, I think, to know who these people are, and importantly, to convince them and to make the arrangements, which is why I've said this exercise is only second, this vaccination exercise is probably only second to an election day activity in terms of national mobilization. They know the vehicles to hire, they know the people to contact. So what we have done is join forces with the electoral office. They have the age ranges of individuals, so we've asked them to provide to their MPs, to the MPs, a list of the over 75s and over 60s, because that's the next group that we will go to. And essentially help to mobilize them with some resources and some town criers and some flyers and so on, so that we really are marshalling a national mobilization effort involving all hands on deck in the interest of overcoming a national crisis that we have faced for the last year. And that's really what it's about. So there's no politics in the play, but we're mobilizing the political organization as part of a unified national effort. And there's no orange or green. So I want that to be very clear. It really is an effort at getting all concerned engaged. And we, who have convinced voters to vote for us, need to go out there and convince those very people why it is important for them to take the vaccine as part of our recovery efforts in the interest of your constituents and by extension of the country. Now, we're not going to be the only ones. As I said, we're doing the church and others, but I think we are likely to be the most effective if we put our minds to it. So that's the rationale for that teaming up. And as I said, we're providing resources, and we're particularly focusing on the Blitz that we will have. But the truth is, immunization is taking place in health centers, in your communities, every day, some 3 days a week, some 5 days a week. So if they miss one, they go to the other. But that's really what the objective is, and we really expect that this will work well if we take a unified front. This is one of the opportunities I think we have as a country, when politics is used for the benefit of all, with no questions or debating around who is what or who voted what. To my mind, it should be a teaching moment for all of us and a learning moment also. Now, I want to complete the circle by just saying that we will have some marshals in the field. So the PS spoke about local government. Minister Desmond McKenzie, who understands the ground a lot in his normal political activity, but also is a unifying force as a minister with responsibility for the local authorities, is going to help to champion that cause and will route some of the resources through his ministry, and he will deal with the councils on what they are to do, and he's going to be in the field also. We have also engaged Senator Natalie Campbell Rodriguez, who is on this committee, who has volunteered her time to be out in the field, and we will probably divide the country into zones. And then, of course, my Minister of State, Minister Cuthbert Finn, is going to also be in the field, assigned a particular side of the country. In addition to that, a board member of each of the regional authorities will be assigned to working with them both to help to be the link between some of the underground organization and the respective MPs and others in the field. So we've identified those 4 board members. There are 4 regional health authorities, and they will know what that concludes is the mobilization, public education, convincing. The clinical side of the formula rests solely with the public health people. So none of these persons are going to be prescribing who should get vaccine or who shouldn't, or whether they must wait 5 days, or they're not. The clinical side will be solely the duty of the Ministry of Health and Wellness and the clinicians. What this team will do is help with mobilizing. Once they get instructions at 60 and over, we go find the 60 and over and bring them out at the point in time that they are needed to come out. So that's really what we have. So I just wanted to bring a little clarity there. I think the PS may have to go. So he wanted to take some questions on the vaccine plan. Oh, you wanted to?
I just wanted to follow up with the answer to Dr. Guy's question. Yes, I believe that the source of the information that foreign companies were testing at the lab may have been linked to an article in the Sunday Observer. That is what I'm aware of. Okay. Just to say that the way the article is worded, I understand the concern. The lab that is doing the test at the airport is a lab that is following our protocols. They are partnering, however, with a US-based company to utilize an app for communicating with their clients. So the US-based technology coming from this firm is used for communicating the results of the test to the persons that they test. But the testing protocols that are being employed are all testing protocols of the Ministry of Health. Thank you.
All right. Sorry. Dr. Hamilton, can we, in the interest of time, get Mr. Zak a quick presentation, and then we just have questions up until 5 minutes to 12, given that we're about 12 o'clock? Is that okay with members? Members? Yes? Okay. Mr. Zaka is you're the chair of the Private Sector Initiative. Okay. So we were invited, thank you for coming, by the committee because they wanted to understand a little more about the MOU and what the implications were for the program. So we'll invite you to speak briefly, and then if there are any questions after.
Thank you, Chairman, and Good morning, members. Good morning to the Ministry of Health and Wellness team. As the chairman said, I am the chairman of the private sector vaccine initiative. It's the PSVI. It is an initiative of the PSOJ and its umbrella organization, the Chamber of Commerce, and the Jamaica Manufacturers and Exporters Association. So it basically covers all aspects of the private sector, including a small business association. There is an established MOU between the private sector initiative and the Ministry of Health and Wellness, and it is a public document. It is listed on the website of the PSOJ amongst other websites, so it is there for the public to see. You know, without going into too much verbiage, Chairman, the primary objective is to increase the velocity of vaccinations in this country and to vaccinate as many people as possible in the shortest possible time. So our objectives and the objective of the ministry as well as the country are aligned. I must commend the Ministry of Health and Wellness. Their team led by PS Dunstan Brand have been amazing partners from the start of this venture, and we've been working very closely with the personnel in the ministry to assist in the delivery of vaccines in whatever way we can. I would say that, well, let me say this for the record. One of our objectives are not to make money out of this, and they are not to jump the line in any way. And we are guided totally by the policies and procedures of the Ministry of Health and Wellness. I would say our initiative has two phases. One is the current phase, where there is a phase one of the National Vaccination Plan, which is targeting the vulnerable population, and at a phase where despite the good news about the number of vaccines which are going to be coming in and have come in, there is still more demand than supply. So for this phase, our initiative is focusing on simply adding our resources to those of the government and the society to assist. So we have members of our initiative that are working closely with the ministry in terms of logistics, in terms of software, in terms of providing lunches. We have donated approximately, I would say about between in-kind and cash, about $14 million so far, 400 tablets to enter data, etc. That's one big chunk. And then I would say the next phase is when, and I expect this to be so, and we all have to be very positive about this, when vaccine supply becomes more pervasive and there is the ability to acquire vaccines in the country over and above the capacity of the public sector to deliver, and where the public sector have accomplished their phase one goals, we feel that it is important that the resources of the private sector, under the supervision of the Ministry of Health and Wellness, be engaged, our team members, our facilities, our money for logistics, etc., to roll out additional vaccination sites under the supervision of the ministry, but with our resources, to target the productive sector, the economy, our employees. That is our focus. And that's about it. There's a lot of more questions than answers, because we're in the start of this. We're all learning, but there is nothing sinister. It's all about helping the country, as the private sector has always stood up to do. So thank you, sir.
Thank you, Mr. Zaka. Very brief, but I think clear, and I think we can get into questions if there are any other concerns around the the private sector's contribution. So we have about 30 minutes, I would say, of discussion, questions. So I'm going to ask you kindly, keep the questions brief and to the point, and similarly so with the answers in the interest of time. All right, I'm going to invite...
Just a suggestion before you invite. Chairman, in light of Mr. Zaka's not being part of the ministry's team, if there are questions directed at him, then I suggest that we ask him first so he may leave at an appropriate time, having regard to his time constraints and the ministry's questions after.
I wasn't aware he had time constraints, but he's a busy man, I'm sure. But there are no rules requiring him to leave on time. But if you want to ask him first, fine. Are there questions from Mr. Zaka first, and then allow him to...
Chairman, let me just say thank you, sir, but you have made copious use freely of my time. So, I mean, in respect to the members of the ministry, I'm here for the half hour.
For the half an hour. Okay, that's good. All right, but thanks for that, member. Considerate of you. Okay, can we begin and then...
Yes, thank you very much, Chairman. Good morning to everyone. With regard, firstly, to the presentation by Dr. Webster Carr, I just wanted to get some clarification. Or is the ministry tracking any readmission due to COVID, and if so, what that percentage might be? And with regard to the vaccination, I am quite pleased to hear of the plan to incorporate the political directorate for the reasons outlined, because just yesterday I was at 2 locations just observing, because I'm curious like that, and noticed that a lot of underutilized, time, not enough persons, if any at all, were at these 2 locations in Montego Bay. And the question that I had was, especially for a location like Catherine Hall, that is in the vicinity, and Member Malahoo Fort would agree, that is in the vicinity of, for example, West Green, that has a high older population. It could do well with people going out and initiating and having them come across. So I'm looking forward to the positives coming out of that effort. In relation to the numbers that you had mentioned before, my question now with regard to the age group and the 75 plus, I have noticed, and I'm aware particularly of cases where one spouse who is 75 is able to get the vaccine, and the other one who happens to be a year or 2 younger is deprived. And I know of someone who has her father going to get the vaccine tomorrow, and unfortunately the mother is 73, and all the friends in the group are getting it, and she's the only one, and she's really rather depressed because she's a willing person wanting to get the vaccine and can't get it. So as we go along with the various age groups, I would like for the ministry to give some consideration to some amount of discretion to be applied, because we all know of cases of 73, 74, 72-year-olds. My uncle, for example, his wife couldn't get it because she's a couple of years younger than him. So if we could apply some discretion in that regard, I'm sure there are ways of verifying legitimacy. That will be my question. So if Dr. Webster Carr could just clarify for me the matter of the readmission.
All right. So let me just answer your last question, because I think it's a policy issue. And then I'm going to ask Dr. Webster Carr to take on the other. First of all, I think we have to be careful that we do not create the impression that somehow people are going to be deprived, because the intention is to ensure that all above a particular age gets the vaccine. The issue is when. So you're a 72-year-old or 73-year-old or anybody less than 75, or those, to be more specific, who don't fit the category at a particular point in time, will eventually get, but we just have to maintain a level of order as best as we can. And we have made errors. There have been margins of error in it. I think that is shown in the inoculation program in terms of persons getting who should not have. But we try to correct it. And the reason for that, member, is that you have to maintain some semblance of order in the administration of the process Otherwise, you run the risk of beginning to make exceptions with others feeling that they are now being deprived, but others are getting a bligh, if you will. And the concept of equity that is captured in the slide that the PS put up earlier is going to be compromised, and that leads to all sorts of issues. So we have really tried, not perfect, to keep it in order and try to be transparent about it. And whenever we have discerned that it is not happening, we have shut down sites. I mean, we have shut down a few sites, then recalibrated, made the correction, and start again. And we have come under a lot of criticism, I know, but we have to maintain order. Now, over time, and hopefully not too long from now, when we have sufficient amounts of vaccines, it's going to become a non-issue. So what we certainly encourage is persons who have not yet gotten the vaccine to take the precaution, but please, we ask for patience and understanding as to why we have to do it the way we are doing it. We're starting with the most risky, and then we move it down the line. And we have to stick to that kind of formula, otherwise it could become chaotic and creating a bigger challenge.
Mr. Chairman, if you don't mind, I really understand and appreciate the point that you made, and I wouldn't want to give the impression that I'm suggesting that we have this whole-scale relaxing of what are rules that must guide the process. I appreciate that. I was only responding or raising the question, especially as it relates to the target that was set for last week or the end of this week, that we are 42% of, and a way to achieving it, especially for those who are not yet encouraged or convinced and are in the category that those two persons who are husband and wife and live together, if that wife or that husband could be afforded at the time. And it's not to advertise, so I appreciate the order.
And I thank you for that. But again, I have to reiterate the point. We have had requests, for example, even up in the Parliament here last evening, for caregivers to automatically benefit when they bring persons who qualify. And it's not that they don't deserve it, don't get me wrong. We all deserve the opportunity to have the vaccine, and that's the government's commitment. But again, there's a risk. There's a bigger risk involved in making those discretionary decisions. And when you have limited supplies, it could undermine the program. But we'll get to all concerned, and we'll get there as soon as possible. I think just give us a little time. All right. Is this related to what was said earlier, or is because I wanted the CMO to answer the question? You want to answer the question that was asked of you, or you don't remember? Oh, Webster Carr, sorry. Okay. And then we'll come to Dr. Brown-Burke. Then we'll come to Hilton, and then we take the front row here. You're going to come after, but you had gotten about 3 questions in already, member, so we'll get to you, though.
Okay, thanks. So just making sure I understand, readmission, not reinfection. Okay, so
yes, readmission.
We will follow persons over time, and possibly with complications. If they are readmitted, then we would identify them. And so Dr. Nadine Williams' team will be the central place in the Ministry of Health and Wellness that follow these persons over time.
Dr. Brown-Burke.
Okay, thank you very much, Mr. Chairman, and good morning again to everybody. I have 3 quick questions. So one was, again, related to Dr. Webster Carr's presentation. And I saw that you said there's an average of about 21% occupancy in terms of the beds. I was just wondering, since that's the average, I assume that there are some hospitals where the occupancy is significantly greater than 21%. And just wanting to find out how we are managing with those and how we are resolving those issues. So that's one. The second has to do with the vaccination process, and individuals who have actually asked me about how you deal with the persons with comorbidities. So I know that there's a little public education session and so on, but individuals are not clear from my engagement with several about when is it you need to talk to your doctor before you go to take the vaccine, or whether or not, depending on the comorbidities you have, what should you be looking for to take it or not to take it, and when do you talk to your doctor? I think that is the question I want to raise. Minister, I'm pleased to know that the church has been mobilized, engaged, and that they're also part of the mobilization. I believe that as politicians, we do believe that we carry sway, but the church has some real power. And I believe that they are in a position to help counter some of the disinformation and stuff that is out there. The other is around the program for those of us who are helping to mobilize, and the reminder for the second vaccine. Does that mean, therefore, that is not just our records that will allow us to remember the second vaccine? Will there be something sent to us for the reminder for the second vaccine?
Okay, and afterwards I'm going to ask you to confine the questions to 2 maximum, please, in the interest of time. Yeah. Yes, Dr. Webster, Dr. Peseso.
Right. So I'll respond to the question in terms of the hospitals where we have over 100%. So essentially, we would have had beds that were dedicated to COVID. And once those are full, then of course we would resort to using beds, beds on the general wards. So it's not, and we have had few instances where we have had over 100% general occupancy and over 100% isolation capacity. What that usually means is that we have persons waiting in the emergency rooms for admission. And so other spaces, what we have seen is that we have expanded, particularly when you look at a hospital like Spanish Town Hospital, their entire waiting area has been converted now to bed space. So you would not have those as documented beds, but a space would have been found and the persons would have been nursed in that area. So that is what happens. I'll ask Dr. Ennis to answer in terms of the vaccines questions.
Thank you very much. We are saying to persons who have comorbid conditions, that's underlying illnesses, they are to take the vaccine. Now, we're speaking if you have any cardiovascular problem, hypertension, any heart disease in your respiratory system, if you have asthma, emphysema, bronchitis, you are to take the vaccine. If you are having lupus, you're immunocompromised, you have lupus, multiple sclerosis, you are to take the vaccine, because persons who have these underlying conditions and get COVID-19, they do much worse. Often they are hospitalized and even die. Now, if also we speak to persons who are HIV, persons who are otherwise immunocompromised, when do they ask their doctors? Now, if any of these conditions are uncontrolled and the persons are extremely ill, then we wouldn't want to be vaccinating them unless they have spoken to their physician. I know what comes up a lot are persons with cancer, and they are very concerned because they may be on chemotherapy or even radiotherapy. Now, again, if these persons are well, they can be vaccinated. However, if you are receiving intravenous immunosuppressive therapy, so if you're getting any IV medication to lower your immune system, then you cannot get the vaccine for a minimum of 14 days after this type of treatment. So for those persons who are on that kind of therapy, they need to be in close dialogue with their clinicians, and we do appreciate if a letter could be written when they appear at the vaccination site, just for our inoculators to see that they have had dialogue with their physicians and they have been given the green light to be vaccinated. But outside of that, once you have a comorbid condition and it's controlled, you're on your medication, yes, you are to be vaccinated.
Okay. You had a question, member?
Yeah, this is for Mr. Zaka. First of all, second?
No, the second vaccine.
Oh.
Oh, so, sorry, member, for persons who have received the first vaccine, what we do is that we write the date of the second vaccine on the card. So all persons should have the date of their second vaccine on the card. They should return to the same site at the same time. However, we will send a reminder through our system for them, but they do have it already on the card.
By way of explanation as well, Chairman, if you don't mind. So yes, you will, for those persons who are operating in the community-based intervention, you will be notified of the second appointment for the persons. So as part of our agreement, you will also be required to mobilize for second appointment.
Mr. Zaka, first of all, let me thank you for coming and for being available and responding to the concerns raised initially in this committee. And just to say that we welcome the input of the private sector, obviously, not least because we know of the corporate social responsibility role that you have played traditionally in this society and in our economy. The concerns really were about given the priorities that has been established by the Ministry of Health and the need, particularly on the question of equity, to ensure that that remains a critical part of the exercise, was to understand then the relationship and the arrangements as they will be implemented and rolled out. Now, there isn't to date a category called the private sector within that health sector prioritization. There isn't a category identified as the private sector or the workforce prioritization. It's a cross-cutting issue, whereas you deal with the priority, particularly as it relates to business, those essential services, for example, are recognized in that stratification. The workforce, you have your age, your retirement age, mainly, in the private sector. The bulk of the workforce are really the able-bodied, the young, and those who are generally healthier. At what stage of this process do you contemplate that focus? Because you talk about the workforce philosophy. First of all, the velocity of the vaccine is, I think, the critical one of the critical objectives. At what stage of that exercise do you anticipate that the private sector will be featured in this rollout exercise? And that's one question. The second question is, as and when that happens, do you contemplate any policies of mandatory requirement for vaccination as part of that rollout within the private sector?
Thank you for those questions, sir. In my initial remarks, I alluded to your first question. And in the National Vaccination Plan, Phase 2 lists a number of sectorial sectors. So tourism, finance, BPO was added, I think, Chairman. So it does list private sector groups that would fall under phase 2. And that is how we are being guided, because that's the only document we have reference to. If that changes, then we will adopt a different posture. But for now, we are being guided by the national plan, which shows that in phase 2, there's a substantial allocation to the employees of various private sector entities or areas. And that is where we think we can play a major role, both in mobilizing, in providing facilities, etc. Within the private sector, we've been talking to our team members constantly, reiterating the message of the ministry that you need to get vaccinated, and we're having a big impact. So our team members are ready to go, and 500,000-600,000 is an easy number for us to deliver in terms of bodies in the private sector. We have taken a position that we cannot force our employees to take the vaccine, and there will be no repercussions to those that don't. But we believe that peer pressure and the example of the society that have taken the vaccine and that are doing well and there's no issues, we think, we did our surveys. There's about 25% hardcore that said they won't take it, but if we get to 75, we think we'll be good.
Can I just elaborate, if I may, on that? To be clear, the vaccination plan clearly states the phases of that the inoculation process would take. Firstly, dealing with the most vulnerable, and the data supports age and comorbidities determining vulnerability. That's where most of our mortalities are. The idea is to deal with that age cohort initially, after we have done the frontline workers, which, as you know, we've been doing, healthcare workers, police, JDF, and so on. Go for the over 75s, then the over 60s, and then I'm hoping we'll go over 50, and then maybe open up beyond that, and in sort of a way to capture the persons who are most likely to be affected. Now, in that regard, the private sector, as described and defined, will be a part of that process, because retirement age is well beyond 50 or 60. So there will be members cross-cutting across industries who will be benefiting and have the right to benefit based on those policy guidelines. And indeed, many are benefiting now, depending on which area you're in. But the phase 2, having ring-fence the vulnerable by age and comorbidity, would now target the productive sector. And this is where the private sector, with some specific professions being listed, and beyond that, everybody. And at that stage, it will be very clear that would represent phase 2. And that would be the best practice, as is the case in all other jurisdictions. And I think that the plan outlines that very clearly. We will discuss, I think, further the approach to rolling out at that stage, because there's likely to be some tweaking. I don't want to preempt the process. I mean, there are some internal discussions taking place, but there's likely to be some tweaking in terms of how we go about doing that, and what role, if any, the private sector would play in that process. But for the efficiency of the process, the speed of the process, I think some tweaking may be necessary. Okay, member.
Thank you, Chairman. Good morning, all. Thank you so much for your presentations. I want to recommend and probably suggest it is a great initiative, the Blitz campaign, to reach the people who need to be reached. There are 2 other dimensions to this COVID pandemic that is hitting very hard, and that is the impact on the mental health and the social health of our people. And, I'm speaking very heavily because just earlier this week, I have had, today is Wednesday, I've had 4 referrals for teenagers who are suicidal. The teen group, the young adults, are getting hit really hard. You know, we really need to be physically distant, not necessarily socially distant. And I think that the Blitz campaign could be used to also address other issues other than just the vaccine. And maybe in the operations of it, you could incorporate getting the message out as to how to help people cope with this, especially social isolation, and especially amongst the teenagers, young adults, and kids who are not able to go to school and interact with their friends, interact with their peers. So if we could maybe develop some strategies that we could pass on to enable them to socialize using, ironically, social media, virtual means to maintain social contact. It is really a very, very sad situation out there with a lot of teens. The other suggestion that I would want to question is there any thought to using, as the concern is around the comorbidities and persons who are high risk, in using the NHF as a guide to identify persons who would be primarily targets for getting the vaccine medically cleared? And my last comment is what I have always brought to this floor, is around immune boosting. More and more we're realizing that our medicine, our food is our medicine. More and more we're realizing how, I go back to the statistic of the higher death rates are from the lower socioeconomic brackets. This is where nutrition and poor nutrition impacts. Again, with the Blitz campaign, can we have the message going out of persons immune boosting, using the vitamin C, the vitamin Z, the zinc, the turmeric, the ginger, enable persons to boost their immunity so that if they get infected, their outcome will likely be better. That's my comments for now, and again, thank you for your valiant efforts.
Thank you very much, Member. Is there any comment in response to, I didn't hear a question, but I heard some important points raised, recommendations. Any comments on that? CMO? I would just like to say, while the CMO comes in, that on the mental health, I think we have been seized with that urgency, and we have had a few initiatives, including the Reach Out Rangers initiative on mental health. We have been boosting the promotion of the mental health hotline, and we have trained in conjunction with, well, CMO, you want to do it? The Red Cross and PAHO, we have trained a number of persons to deal with coping mechanisms as part of the mental health response linked to the isolation or restrictions that we have had at all ages, including the young people. So there have been evidence of more persons seeking help, and we have had more deliberate reach out programs to give support where we discern that support is required. And those persons that have been trained would then be trained to identify persons in distress, to offer basic support, and then, if necessary, recommend to the more trained professionals to the highest level, including your own area of specialization, Member. And that, I think, I don't have any data to see what has happened there, but I know that has been a critical part of the issue. And then on the food issue, the NCD campaign that we have as an ongoing is an area that I think we need to link more with the COVID-19 response. And it's something that we've been pushing for in the ministry. Maybe the clinicians can speak a little more on that. CMO, you want to come in now?
Yes, I think the points are well taken. And what I would suggest, Minister, is that in our next meeting, we ask the mental health team to do a presentation. We've had several initiatives starting from early last year in terms of really, first of all, recognizing that this is a problem. And I've had several initiatives, some of which Minister has mentioned, to target it. And we do have a child and adolescent health section of our mental health unit, and they have also put in measures in place. So I think that for the next meeting, we will ask for a presentation on that, but the points are well taken. In terms of the nutrition and using the Blitz operation, I think that's a good idea. And we have been looking at how we strengthen the health education part of the Blitz campaign. And I think that this is something that we can incorporate.
We don't have a lot of time, so...
Just a quick one. I had it written down and I forgot to ask. In terms of the rollout of the vaccine and the priority groups, and especially with, as I mentioned, issues around kids being home, and where does the education sector and teachers especially, and the rollout for return back to school, where might that fall? I'm not sure if I missed it, where it might fall in the vaccination program rollout.
Okay, teachers are part of our implementation for April. So we begin vaccination of teachers in April as a part of the priority groups. You recall the cabinet decision that teachers should be part of the prioritized group, and it is our intention to begin vaccination of teachers in April, subject to the availability of vaccines, of course.
Thank you very much. There are, okay, Member Mallory Fort, AG.
Thank you, Chairman. Permit me firstly to commend the health team. Every time I see your core team showing up in different places, Minister, I can't help but think that in spite of the many challenges, how well they have been able to put information in a reader-friendly format for those of us who are consuming it. I know it is not easy, and in spite of all the challenges, I have been reading the rollout of vaccination across the globe and all of the issues. Sometimes we believe that issues are unique to Jamaica, but in fact, I think the team has led and managed well, and I want to put on record my commendation, firstly.
I want to say thanks on their behalf.
Yes, Chairman, you may accept it too. A number of legitimate concerns have been raised about the policy decision regarding priority at this time, given the limited number of available vaccine on the island. We know that supplies will roll out later on. I would like to suggest that perhaps some focus be given on clarifying the message as to why the priorities are what they are at this stage. Because it is a legitimate concern for someone who is in a household with persons who would fall in the priority and others who do not, and how coexisting in that household may cause genuine fears about contamination and contracting the virus. I think that is the one area that some more clarity and reiteration of why the priority is, while reassuring that all steps have been taken and continue to be taken to have the supplies here, and as soon as they're here, then everyone who would be eligible for vaccination would be vaccinated. Thank you.
Thank you, Member. I think that is fairly self-explanatory. And we have attempted so to do, but I think we need to keep doing it. So I think your point is well taken, so we'll note that. And thank you also for your commendations to the team.
Thank you, Chairman.
Okay, I'm assuming you don't have a question, Member Cameron Rodriguez? Okay, so Member...
Thank you, Chairman. Dr. Ennis, I think it would be instructive, the slides that you indicated in terms of the age cohort, the groupings, it has a potential to be misleading because we're not giving anybody under the age of 18 the vaccine. So probably 0 to 19, seeing that, it gives the impression that people under a particular age are getting. So it is something that may be misconstrued. Right? 2, the matter, Minister, you indicated to Parliament yesterday that there are 12 sites that were going to be started on April 9th. Presentation today said April 10th, but there were 4 sites that were not on today's presentation that were yesterday presented to the Parliament, and that is the one in Lucy, Folly, Portmore. Is that we having a change now, or are those going to be added to the listing that you have presented up there just now? Dr. Webster-Carr, I noticed the presentation you indicated that in terms of the 5,000 numbers, you 14, 10, 9, 15 days to get another 5,000, right? And you indicated that the doubling had moved from about 150 days to about 70 days now. Am I correct? Right. Now, I find that a little challenging to accept, interpret, and understand when, against the reported pronouncements by the Honorable Minister and the CMO, and I would not expect the Minister to say matters relating to public health because he's not schooled in that area. But to say the CMO was quoted in the Star of March 24th to say that maintaining high level of testing is an inefficient use of resources, is that to imply that we are no longer testing that amount of persons now? And hence, if you're not testing those amount of persons, then certainly your doubling time will be reduced. Now, the reality is that, the question I'm asking, is it that we are testing less persons? Yes, we have seen daily numbers coming from the ministry which suggest that. And the mention of not doing contact tracing is also a matter of concern. Yes, I recognize, and we all do, that we are in the community spread phase, but it is still part of good public health. We may not know in a community spread phase who a person may contract the virus from, but certainly we should contact trace those who we know have the virus and live in an environment or household where other persons are infected, so contact tracing ought to be done then, even if you don't know where John Brown or Mary Jane got it. So to say that contact tracing is somewhat, in terms of the numbers now diminished, is unfortunate because the country, the health ministry, the clinicians, the scientists need to know exactly what is happening. And we give a misrepresentation of the numbers if we do not test as sufficiently as we ought to. And it is still, irrespective of the phase that we are in, the guideline of WHO that we test and trace.
Remember, not to disturb you, but we're 4 minutes to 12.
I know,
and if you're going to get responses, you're going to have to be more succinct with your questioning rather than the commentary.
Enough,
so to give them an opportunity to respond.
Right. I just want to say that the answer to the question must be taken in the context of the entire narrative that was said at the press conference. First of all, the first thing was that we have maintained our testing and contact tracing, but what was stated was that it was unfortunate that we still have to use testing and contact tracing to drive precautions. Because at this point in the epidemic, we would have hoped that the level of personal responsibility would be what is driving precautions. In terms of what directs our public health interventions, it's really the positivity rate. And the positivity rate is going to be the same or thereabouts, because we know that the more you test, the better level of accuracy you have. But certainly we would have the same kind of guidance, whether it is that we're testing 500 or 1,000, because the positivity rate would remain the same, and that is our main driver of precautions that we put in place. And also the admissions, because we will see that our admissions and our hospitalizations follow the positivity rate. Now, we have been asked for different ways of putting forward the data, and we have done that because different persons require different ways of seeing it. But it is not every way that the data is presented is necessarily what is driving our interventions. So, for example, looking at our doubling rate, it certainly gives us an idea, but it is not new information, because we would have seen that our positivity rate has been increasing. So this is not new information that is there, and that is not what is going to drive our data, because even with smaller numbers, we could have seen a difference in the doubling rate that would have indicated something else. So we have to be very careful what are the points that we are using to drive our interventions.
Semo, I understand what you're saying. I just want it to be appreciated by the public out there that it was taken out of context. I think that is the essential point I want to make.
Okay, thank you. Thank you for that. And I'll ask Dr. Webster-Carr to add.
Are you speaking on the same issue? No, because I wanted to speak to just for a minute to it. I know we're against time, remember. No, because it's important. I've seen in the media space various advocates, including yourself, but many others, speaking about testing, almost as if testing represents the solution to the COVID-19 pandemic. And, you know, I may not be trained in clinical science, but I'm a quick learner, and I've been well schooled by the group of experts across the aisle, certainly over the last 4+ years. The fact is that beyond a certain point, you're really testing with the same results. And because that's the way the statistical modeling works. And I think the CMO is correct in advancing that. So I do agree that there's a level at which you should not go below, but there are optimal levels, and there are levels at which diminishing return sets in, unless your objective is to test to determine infection as opposed to prevention of the infection. And that is, I think, the point that has to be made to the populace. Testing will give you an indication of the challenge, and up to a certain point, it will be very obvious what the challenge is. It is on the prevention, which is the protocols that we have announced, where we are going to address the real issue of not having the virus in the population, and I think that is key. Secondly, on contact tracing, you have seen a map of Jamaica, and the epidemiologists say that every single community in Jamaica has at least one case, or certainly thereabouts, right? We do not have enough people, practically speaking, to do the type of contact tracing that we engaged in the early stages of the virus. And indeed, there was a point when the team said to the country that there would come a point called community transmission when contact tracing becomes impractical. And so this call, I think, is a call that is not sufficiently informed by the science, and frankly speaking, is theoretical and really does very little to address the issue of preventing the spread of the virus. I think our efforts are better placed on pushing for the protocols to be observed, and of course in the vaccine plan that we are now rolling out. Remember, I'm going to allow you one more question in the interest of time.
It's just a comment to your commentary, Chairman. With the greatest of respect, I would advise to keep to your core knowledge. The truth is, Minister, that what you're just saying is totally against public health. And you could be a fast learner. The reality is that there are implications for what is being said and implications for what is being done. And I think that if that is the information that you want to give to the populace out there, then you should couch it in the language that it is because of this, that, and the other, why it is so. But to say that those long-shared, long-standing public health measures are really counterproductive and that they have diminishing returns, I think it's an unfortunate statement.
Member, we'll agree to disagree on that. Epidemiology is not just clinical science, it's also about statistical modeling. And I've done a lot of it in school. So the point is that we have to just be careful that we do not send a signal to the population. That's the point I'm making. That it is the solution to the COVID-19 virus spread is in testing. Because it is not, and I repeat, it is not. It is observing the protocols that we currently have announced, the wearing of the mask, the physical distancing, the sanitizing. It is in the vaccines, which we are placing great hope so that one's immunity can be built up. And there are several other things that are necessary. Testing is to give us an indication of the extent of the virus in the population. And statistically, there comes a point when testing everyone is not going to tell us a lot more about what is happening. And I maintain that position. But thank you for your points, because I think it's necessary to ventilate the issue and to give the opportunity for the public to have a better understanding. I see, even though we're against time and there's another meeting, right? I'm going to ask you 30 seconds, and then I'm going to ask the CFO to wrap up.
Just very, very quickly to say.
Okay, Chairman, I just wanted to make a quick comment as we are going into this lockdown coming this weekend. It is very heavy for the country. It is what we have to do. I implore you to organize the time to reach out to other members in your family, to persons who you know might be going through this alone. Set up activities for your children. Get back to the board games. Don't watch too much of the news. Know that this will pass. And of course, I am always about the vitamin C. A lot of persons might be going into the resilient corridor. Maybe we can encourage the use there. The shopping centers where a lot of people might be gathering and persons who may be still going into work, the essential services, we can encourage the use there. But I am very happy to see that we're having some sort of plateau, and it is very critical that we stick to the protocols, especially this weekend and beyond. And we will get through this.
Thank you. CMO, you want to close?
Yeah, just very quickly, just to ask the population really to pay attention to the positivity rate, because that is really what will drive the interventions that we want to see.
Agreed. And in closing, let me thank all for being here. Thank you, Mr. Zakov, special invitee from the private sector. Thanks to the medical team, the health team. Thanks to the parliamentary staff. And to our colleagues on the committee, thank you very much for your input. I want to wish you all a peaceful, reflective weekend. It's a weekend that is going to be unusual. And to the population, I want to say, please, spend the time to reflect on the meaning of the season. It is one of the most significant periods in the Christian calendar, and it is a time for sharing, for reaching out, and particularly in these times with the restrictions, if we have to use the electronic means, reaching out could be the best thing that can happen to someone who may be otherwise lonely, depressed, or just feeling left out. Beyond that, use the time to get some rest. The country has been experiencing significant anxieties. We've had to experience a year of this COVID response. It has affected us in all forms, all ways. And I think this weekend will add to that if we focus on the negatives and not on the positive. We're alive, and we give God thanks for his mercies. Thank you very much. Meeting adjourned.
Strange as it may sound, Chairman, I agree with you.